This is a traumatic subluxated cataract where I'm using iris retractors and a capsular tension ring to stabilize the capsular bag and the rhexis. You will notice the inferior subluxation of the cataract here with a fair amount of vitreous show into the anterior chamber. Capsular rhexis in such cases is performed very slowly and meticulously, preferably using sodium hyaluronate to stabilize the chamber and avoid frequent shallowing of the anterior chamber, which may precipitate more vitreous coming into the anterior chamber and also subluxation of the nucleus within the vitreous cavity. Having completed the capsular rhexis, we proceed to make 4 different side ports. From each that side port, I would introduce an iris retractor. Now this iris retractor would not be used to retract the iris but to engage the anterior capsular rhexis margin and pull it upwards so as to stabilize the whole bag of the lens. With 4 iris hooks in place and now the cataract fairly stabilized, I proceed to remove the nucleus, which is relatively soft in this case, using very low phaco, low flow rate and low vacuum, and also a low bottle height to avoid a sudden deepening of the chamber and the subluxation of the cataract. Having removed the nucleus, I attempt to remove the cortical plate, but I notice that the moment the cortical plate is removed, the whole capsular bag tends to collapse on itself. To avoid that, I use a capsular tension ring which is introduced within the capsular bag and distending the capsular bag back to its original size. I then proceed to remove this thick cataract plate. Having removed most of the cortical plate of the cataract, there is only a little remaining cortex in the subincisional area, which I try and dislodge using my left instrument. This plate is engaged behind the capsular tension ring, so it is not very easy to remove. So I instill some viscoelastic before I remove my phaco handpiece probe to avoid an anterior chamber shallowing again. You will notice that I am using a blunt edged instrument to remove the cortex which is trapped beneath the capsular tension ring. Having loosened that, again I enter the chamber with an irrigation aspiration instrument and I, using a low vacuum, very slowly and gradually remove the remaining cortex from this cataract. Once this cataract is cleaned, we proceed after instilling the viscoelastic and removing one iris hook. You notice there's a decentration of the rhexis because one of the iris hooks has been removed to facilitate the insertion of IOL and dialing of the IOL inside the capsular bag. I prefer using a non-folding IOL in such cases because at times the unfolding of the IOL itself may cause further damage to the already weakened zonules in such a case. I instill the viscoelastic and insert the lens within this small capsular rhexis. After inserting the IOL, a viscoelastic is again inserted to distend the capsular bag. Using a Lester's manipulator, I dial the IOL within the capsular bag. Noticing an incomplete entry of the IOL within the capsular bag, again more viscoelastic would be inserted because one of the hooks on the superior left side has come loose from the anterior capsular margin. Now this hook will be re-engaged with the anterior capsular margin, which is slightly difficult in this case, as you are seeing, because with the IOL in place and the anterior capsular rhexis margin behind the IOL, it is difficult to engage onto the same rhexis margin now. Nevertheless, with a little bit of patience and luck, I am able to engage the rhexis margin and pull the rhexis up again and now my IOL is ready for dialing within the capsular bag. As I dial the IOL in place within the bag, you will notice how beautifully the lens centers and the CTR takes its place, and the whole cataract is gone with the IOL exactly in center. Having done that, I remove the iris hooks, instill some pilocarpine in air, and give a subconjunctival injection to this patient. This patient was 6'9" unaided the next day.